Should we get started then? Thank you all for coming. So my name is Peile and I'm a clinical psychologist in the young person service based at the Maltese for OCD and BDD.
And I'm Katie Lang, I'm a clinical psychologist working in the same service.
So the plan today, obviously we're not going to be able to go into lots and lots of detail about how to provide treatment for BDD, but what we want to do is to give enough of an overview so that people kind of know what they're looking for, what kind of features are really important for effective treatment. And we're going to base that on what we know from research, what we know from our experience. I imagine there's lots of lived experience in the room, and we'd be really keen to hear from all of you about things that you found helpful or less helpful in regards to BDD treatment. So use the space informally, put your hands up, ask questions, stop us if you want us to clarify anything. We've put together a set of slides which we think summarises the most interesting, important things, but there may well be things not on here that you want to ask us about, and that's fine as well. So it's always tricky to judge. An hour is quite a short amount of time when we do these presentations to kind of, in terms of learning about CBT for BDD, we sometimes take a whole day. So we've really tried to squeeze it into what we think the most important things are. Anything you wanted to add?
No, I think that's so good. No.
So we thought we'd start off with, some of you may have seen this clip. So recently we were involved in putting together the BDD Youth website, and some of the young people that have had treatment with us were involved in creating videos to talk about their experience with CBT. So what we thought is we would start off, we're just going to show you a few minutes of people talking about what they found helpful in CBT. So I know some of you might have seen these videos before, they're on the website, but yeah, we're going to just...
When I got diagnosed, I didn't think that it was right, because as somebody with body dysmorphia, you just think you're ugly. You don't think that there's anything wrong apart from your physical appearance.
After I was diagnosed, we started to pick up on more symptoms of BDD and realised that it was BDD, and that really helped to take the next steps into therapy.
I had CBT, cognitive behaviour therapy, and exposure therapy. It just involved a lot of exposure tasks and opening up to the therapist, Benny, I had, and just letting her into what is going on in your head and how you think this has happened, and just exposing you to your fears to gradually allow you to get over them.
It didn't feel like I was being judged, and I think Angie was really helpful, and she didn't make me uncomfortable, and I was always able to speak.
I didn't have much hope at first, but the more sessions I went to, the easier it got, and I just thought I might as well give it a try. And the more I did, the more I felt I could do.
During the treatment, when I was seeing other people say things which were similar to things I would kind of tell myself, it's easier to see how that could be misguided, perhaps, and that I wouldn't want them to feel that way, and wouldn't want myself to feel that way either. So that was very motivating and inspiring, I think, to be amongst other people whilst doing this.
The most memorable moment was when I wiped my makeup off for the first time. It had been about 3 years then, without my parents being able to see me at all without makeup on. One day I just decided to wipe it all off and walk downstairs. Everybody was crying. Yeah, felt good.
I think it was the first day that I got up out of bed, and I just put on whatever I could find and I went out, and I think that was really nice. And it doesn't seem like a lot for someone who doesn't have BDD, but to me it's a really good thing.
It was when Benny, my therapist, came all the way to my house to go to school with me to face my biggest fear of going into school with no makeup on. We got the train together into school, and then she walked me into school and she stayed with me for a bit, and she was like, I'm always here, like if you need me, just come out of lessons, I'll be here for you and we can go, but I really think you should face it because it'll be so beneficial for you. And I was like, yeah. And because of how I managed to stay in school the whole day with no makeup on, which was I never thought it would happen.
Some of the tasks I did when I first started seem really, really easy now and when I started they seemed like the worst thing in the world.
Thoughts of my appearance used to be very life-denying, and now I feel like it's not something which stands in the way of doing things I want to do.
Everything's become a lot easier and I'm able to deal with it, and it's not overwhelming and really difficult anymore.
Obviously I still have thoughts sometimes, I have bad days, but most of the time I have good days, and the bad days are rare now, when it used to be the other way around.
There are still things I stop myself from doing, but ultimately I'm doing a lot more than I was allowing myself to do before. My confidence within myself has definitely increased.
It feels, I don't know, it just feels like different. You feel like the same person, but with a new look on life. And it's nice, it really is.
So that was really just to set the scene and just to remind us kind of some of the key things that can be really important in CBT and BDD. So what we're going to do now is to go through some of that in more detail, and like I say, do ask us questions if you want to at any point. I think the next one. So this is what we talk about when we talk about NICE guidance. So I don't know if people are familiar with this organisation, but essentially for every health condition there are very clear guidance set out, very much embedded in the evidence base to say how you should treat each condition. And these are the guidelines for BDD. You can see they were published in 2005. So what happens is there's a kind of surveillance process, they call it, that happens every few years, and they look and say, is there anything new that means we should update the guidance? And I think in 2019, the decision was made that we do need to update the guidance because there's been some, I guess, new research coming in and new treatments developing. That hasn't yet happened. So it's a slow burner within NICE, and often it can take a while, and there's lots of advocacy going on behind the scenes with people saying you need to look at this condition, and obviously there's battling between which condition should be prioritised for the next set of guidance. So it's something that our colleagues are involved in trying to update the evidence base. I think it's unlikely that this is actually going to change. I think what will probably happen is new treatments might be added in, or kind of new bits of research that might help us to understand BDD a bit more. But essentially, this is what we're talking about. We're talking about exposure-based CBT and medication. So SSRIs, selective serotonin reuptake inhibitors, otherwise known as antidepressants. And we know that they are used in higher doses and are typically used generally for mood and anxiety. So this evidence base is essentially the same as for OCD. So we've got quite a long history of research for OCD, far less for BDD. We know it's a kind of a condition which is only recently really emerging as something that people are really looking into and researching more. But we know there's sufficient similarity between the conditions that lots of what we've learned from OCD is really helpful for us understanding how to treat BDD, and that's certainly the case with medication.
So this slide really just gives a bit of an overview of what the structure of CBT for BDD might look like. So again, in terms of the research that we have, and this might differ in terms of the exact number depending on the service you're accessing support from, but we know that there's what we have a good dose of CBT for BDD in terms of the number of sessions, and this is somewhere between 16 to 22 sessions. Like I said, this would differ depending on where you're accessing it. If it's an adult service or a child service, it might differ a little bit, but somewhere between that number. The other really important thing about the sessions is that they're weekly. So again, the research that we have shows that we see the best outcomes when sessions are weekly, and that's because there's something about the momentum of CBT, I think, and that's not just the case for CBT for BDD. I think it's across the board for all disorders that we see. So having those sessions weekly, we see much better outcomes, so that's super important. The sessions will typically be 1 to 1.5 hours. In our clinic, our initial sessions, we tend to do 1.5 hours, and then the weekly sessions will come an hour, but again, somewhere between that. Homework assignments are super important, so having that weekly hour and a half with your therapist is really important, but then it's kind of the work that happens in between, again, that's really important as well. Kind of, you've got that hour with your therapist, but then you've got all the other hours in the week that you kind of need to keep up the fight against BDD, so the homework is an essential part. A little bit about treatment for young people, so those under 18 years of age. So again, these sessions are likely to be tailored for the developmental age, for their ability. So for example, perhaps having longer sessions on learning about anxiety, which we'll go into a bit in a minute. They might take what we call more of a behavioural approach, where we're really focusing on the BDD behaviours and then changing those behaviours to see the difference in distress. And also parental involvement. So in our clinic, we know that having parents involved is something that's really important. So either involved in the entire session, involved at the beginning when it's that education sessions, or kind of having that check-in at the end so everyone's on the same page. And I guess that's because BDD is something that can kind of draw everyone in. So having everyone on the same page, knowing what's happening, knowing how to fight it, is essential as well. So a little bit about what the initial sessions might look like. So starting off learning about BDD and anxiety, so these are often called the Psychoed sessions, psychoeducational sessions. Lauren's going to go into a bit more detail about some of this, but learning about BDD, learning about things that we know make BDD better, make BDD worse, and then also learning about anxiety and what the role that anxiety plays in keeping BDD going. Moving on to thinking about what we call the formulation, which I guess is just thinking about how the problem developed and trying to make sense of what's happening here and now and what's keeping it going. So like it says there, how's this problem developed? Spending some time thinking about past experiences that may have kind of fed in and shaped people's beliefs about appearance, about themselves, about the world in general. Thinking about why this matters, the kind of meanings that they've taken from these experiences and how those beliefs have developed. But then really thinking about what is keeping BDD going in the here and now. So what are the behaviours that are happening and how anxiety is kind of playing a role in keeping that distress going as well. And then goals and motivation for treatment is super important. So CBT is a really difficult treatment. Sometimes when we meet young people at the start of treatment, they might be really ambivalent about coming to sessions. They might not be sure about talking about BDD. So we really spend some time thinking about I guess goals related to how we can sort of maybe decrease the distress, but also kind of open up life for them a bit more, where BDD's kind of taken that away from them as a kind of motivator for treatment. And then building a hierarchy, which again we'll go into a bit more in another slide, but this is really creating a list of all of those BDD behaviours, because we know that those are the things that are kind of maintaining BDD and keeping it going in the here and now. So, thinking about psychoeducation, one of the first things that we start doing is learning about anxiety and really learning about what we know about how anxiety works generally, but also learning about the role that it plays in BDD. So this is a slide showing something called anxiety habituation, which is thinking about what happens when you face a scary situation and stay in that scary situation without doing anything to kind of change that anxiety or change that distress. And we know that the way that anxiety works is that if you're able to do that, eventually over time that anxiety is going to decrease on its own, or that distress is going to decrease on its own. So we're talking about that, and then we're also talking about what happens when you repeat that experience over and over again, with the message really that over time anxiety comes down, but the more that you face that scary or anxiety-provoking thing, the easier it gets over time. And this is a really important message because it really sort of relates to a key ingredient in CBT, which is exposure and response prevention, which we'll talk about in a bit.
So these are some of the other things that we include in our psychoeducation, so our learning sessions that happen at the beginning. And I should say as well, this is all in our manual, so we have a desk or a table just in the next room, and we've actually bought one of our manuals if you wanted to have a look through it. And we're really excited that quite soon we're going to be making our treatment manual freely available to clinicians, professionals who want to learn about how we offer CBT for BDD. And I think that's something that is part of our kind of really wanted to disseminate good practice, so that everybody who's receiving CBT, not just from our service but from other parts of the country, are able to be offering a similar kind of evidence-based effective treatment. So anyway, this is one of the things that we look at. These are some of the kind of exercises that we use, and you can see that it's taking kind of everyday I guess things that we know about, and we're not necessarily going straight in and talking about appearance. We're actually thinking more broadly about how perception works and how the brain kind of understands visual information, and especially for young people or for anybody who is a bit ambivalent about treatment, they're not sure if they're really wanting to have CBT for BDD, they're not sure if it's going to be relevant for them. I think it can be quite helpful to be taking a step back and thinking a bit more broadly as we get to know them and they get to know us. I often find these sessions can be quite helpful just to kind of settle people into the process and do something that doesn't feel quite as threatening as immediately talking about people's appearance worries. So yeah, I don't know if these are things you've seen before. So the dress, do people remember when it was kind of all over social media, everyone was arguing about what colour the dress was? You know, we use that as an example of how subjective perception is, how actually different factors can change what we see, but also between what different people might see at a given time. And that's often the kind of idea that resonates and people, gets the cogs turning a little bit in terms of how we're perceiving the world and how that might actually apply to appearance as well. Similarly, the which line is longer, which, I've had people getting out rulers and not believing me when I say the two lines are actually the same length, even though our brain kind of tries to tell us otherwise. And then the dots, so in between the intersections of the squares, it looks as though they're kind of little splodges and dots, but actually there's nothing there. So these are just kind of slightly playful ways to introduce the idea about perception being unreliable and how that might be something that could potentially apply to some of the cognitive biases and distortions and tricks that BDD is playing. And this is another one. I don't know if I don't want to give the game away and say too much about, but the first is a video which kind of tries to trick people basically, and plays with this idea that if you're really focused on one thing, you can start to lose your focus on other things, you can miss other important information. And when it comes to self-focused attention, which we know is a really kind of key attribute of BDD and the way that BDD kind of works, it means that people are going about their everyday lives missing out on really important bits of information, whether it's socially, whether it's people kind of being kind to us and us writing that off because we're so focused in on ourselves, or lots of, obviously with learning opportunities, there's lots of different ways in which that real reliance on self-focused attention can be problematic. So yeah, there's a like I say, I'm not going to tell you exactly what happens in that video, but there's a bit of a curveball that always takes people by surprise when we do that in the session. We do exercises around really practicing paying lots of attention to a particular body part, obviously choosing something that doesn't relate to somebody's BDD, because we're not wanting to trigger distress, we're just wanting to kind of see what happens when we put lots of attention on a random part of our body or anything at all, like actually how we start to really notice different things that we didn't notice before, how it can really start to make us hone in and zoom in on imperfections that we wouldn't have noticed if we weren't really kind of hyper-focused in that way. And then this, what we call the spotlight effect. So this idea that all humans do, which is that we assume that other people are seeing what we're seeing, we assume that other people are thinking what we're thinking. It's kind of a very natural, automatic thing that humans do, but if you're somebody with BDD and you're really focused in on a particular feature, your assumption is that other people, when they walk in the room, are zooming in and spotlighting that feature as well. And we have kind of exercises that play around with that idea a bit and try to, I guess, bring a little bit of curiosity about whether or not that might also be contributing to somebody's distress. But as I say, at this stage, we're very much trying to keep this broad and curious and kind of educational, rather than expecting people to go into lots of detail about their very specific worries and fears, because it can take a little while before people are ready to do that. So this is the formulation that Katie referred to. I'm going to just bring it all up. But this is about how we map out how BDD works, how we understand how BDD is working, how we really understand this cycle bit. So this is the key, this bottom bit here, you can see the arrows kind of go around in a complete cycle, and that's what people get stuck in. So this cycle between the thoughts, the distress that causes, and all the behaviours that people understandably try to do to reduce that distress, but how actually that's counterproductive, because all of those behaviours actually increase the focus on the negative thoughts and also contribute to the negative critical beliefs that people have. So it's really important to kind of establish, firstly, I guess, that bottom bit of the cycle and how that's actually acting as this kind of perpetual fueling of BDD and distress. But then the other thing we do at this point is we also look back into people's lives and experiences and try and understand where those beliefs have come from. And they can come from a whole range of factors. Some of them are very individual kind of events that have happened to them. Some of them are actually about being in society and the messages we get and what family ideas are and all sorts of things. There's no right and wrong about what we include in that. But we're trying to really, I guess, help people to understand how they've got to where they've got to with those beliefs, and actually how those beliefs aren't helping them. And potentially the behaviours that they're doing are actually stopping them from having any other beliefs and opening up their world to things that might actually start to either soften the rigidity, that's a hard word to say, rigidity of those beliefs, or actually give them other ideas that can help to balance those out a bit. And what we know is that when people have BDD, they can become really, really kind of stuck into a very, sometimes quite small world where these beliefs don't really get challenged, and that can obviously be very counterproductive. But this process can sometimes take a few sessions. For other people, I think the process of looking back into their past experience is actually quite difficult, and they prefer to move on and just kind of look at the here and now and the concrete behaviours. And yeah, for some people actually this is a really important and helpful process that they want to spend more time on. So we're always kind of working out the kind of the speed and the timing of this for each individual. For some people actually it might be a little bit further on in their recovery when they want to come back to this and really think about their past experiences, because in the early days this feels too difficult to do. But it's a key ingredient, I think. Was this me as well? I think it is. I think so this is ERP. So I'm assuming everyone's heard of ERP, exposure response prevention. You'll see it all over any of the literature about BDD, and it's something that has very much been developed with OCD in mind. So this is something we know works really well when you have a condition which is around doing behaviours to reduce anxiety. And what we know is that the key ingredient of CBT for BDD is that exposure. So facing the fear. It's a key ingredient, but right, it's incredibly hard to do, but it's the thing that really counts. And without it, it's really hard to make progress, because the avoidance, as I said earlier, stops you from learning anything different about the beliefs that you have. But what's really important, and this is where you have the E, which is the exposure, but then the response prevention. Quite often we meet people who perhaps have had CBT before, or maybe have even tried in terms of self-help to do this themselves, and they've only done one bit of it. So often, you might need to take over if my voice is up. Sometimes they've done the exposure, so they've gone into really difficult situations and they've really faced their fears, and but what they haven't done is reduce the safety behaviours and the kind of sometimes quite subtle things, maybe things in their head and reassurance, or making sure someone else is with them, reassuring them. So even though they've done the really difficult thing, they've not done the response prevention. Other times, people might have been really working on reducing their behaviours, but they've not done the exposure part. So maybe they've only done it in their room when no one else can see them, or they've only done it when they've had makeup on, or there's been something else that's meant that although they've worked really hard on the behaviours, it's not been kind of combined with the exposure. So that can be quite, it's important to try and find tasks which really bring both of those bits together. And I don't know about you, Katie, but I think quite often that's one of the things that's been missing, is people haven't managed to do both together. Could you do this bit while I get a drink of water? I'm so sorry, everyone.
So here's some examples of some exposures. So for example, going out in public without wearing your makeup, so the kind of going out in public would be the exposure, and then reducing that safety behaviour of the makeup. We'll talk a bit more because, as Lauren was saying, I think the devil's in the detail with exposure tasks, and kind of planning how you go about doing it is the real kind of key bit. Leaving the home without checking the mirror. So often people sort of tell us that when they face that fear, another kind of compulsion of kind of checking the mirror or checking car windows to kind of as a safety behaviour to kind of see how they're looking or how they're coming across to other people. Using different shampoos, going to a shop without wearing a hat, making eye contact with someone at the bus stop, which I think is a really key one actually, because I think that's one of those ones that kind of can go under the radar, kind of eye contact. So why do exposures? So as I mentioned before, when we do those anxiety psychoed sessions and learning about anxiety, it's really, the exposure is kind of the live way of learning that when you're in that scary situation and you drop that BDD safety behaviour, that anxiety does reduce over time. It might take a little while and it takes a few practices, but with that repeated practice, you do see that reduction in distress or anxiety. To gather evidence and challenge beliefs. So I'm going to talk a bit more about this in a further slide, but I guess a big safety behaviour that we often see in BDD is that avoidance of going out into these situations. And as Lauren was saying, when we sort of unpick that in the formulation, where we see these beliefs that people have about themselves or their appearance or the world and appearance, they're obviously, the BDD has kind of shut down their world and not giving them the opportunities to kind of disconfirm that belief or gather other evidence that might kind of say otherwise. And I guess that's what exposure kind of pushes people to do. So, for example, some of these beliefs might be that people will treat them poorly, so how people are going to sort of react towards them if they don't do those safety behaviours. No one's going to want to be near me. And also really important about people's ability to cope with distress and with those negative beliefs that they have. But also a really huge one, I think, is to build self-esteem and think about those other areas outside of appearance. So often in BDD, I guess, self-esteem is quite, I guess appearance is a driver of self-esteem or self-worth. They're kind of really tied into each other. And by doing those exposures, by kind of putting yourself into those different areas of life, it gets an opportunity to kind of broaden that out a bit. So this slide is thinking about how it works. So like I said, I think, as I was saying, Lauren, I think the devil's in the detail when it comes to kind of planning exposure tasks, and that's why it can get really tricky. So step one is we build what's called a hierarchy, which is essentially where we sit down and we make a big long list of all of the BDD safety behaviours that person thinks is going on for them at the moment. And then we put them in an order, where we rate them. We give them an anxiety rating of how hard it would be to kind of expose yourself to that and not do that behaviour. So essentially what we're looking to do is kind of put them in a bit of a ladder with easier ones at the bottom, easier ones that would be easier to kind of stop or reduce, working up to ones that would be higher up there. And then it says to design your exposure task. And what we want to do is going in at the bottom of that hierarchy, really. We don't want to be starting at someone's top of that ladder, because essentially what will happen is they'll probably go into that situation, try really hard not to do it, but will be completely overwhelmed, and it's kind of setting themselves up to fail. So we start small. It's a very stepped and graded process, and the gradedness of it is something that's so important. To make it specific, so we'll pick one thing and we'll be really specific about what that task is, what are the behaviours that they might want to watch out for that might pop up if they stop one behaviour. It's quite often that, other behaviours might start coming in, so really thinking about that. And like I said, making it manageable, breaking it down into a real manageable sort of bite-sized task. A really important step is monitoring anxiety over time. So we get people to sort of make anxiety ratings, really, so get them to check in with how anxious they're feeling before they do the task, and then as they're doing the task, sort of checking in sort of every 10 minutes or so. And this is to see what happens to that anxiety over time and see if we're seeing that anxiety habituation, getting used to that anxiety over the time. And because of that, it's really, really important when doing an exposure task that it lasts long enough to kind of see that anxiety habituation. So, for example, if the task is to kind of go out in public without wearing a hat, that you're kind of out in public for long enough to allow that anxiety to come down. If you kind of go back too soon, then anxiety is going to go straight down. And what we want to see is it kind of come down slowly over time, where you're kind of getting used to it and seeing that you don't need to be doing those BDD safety behaviours in order for that distress to diminish. And then the last important step is to really reflect on what you've learned from doing that task. They're really hard tasks. You're pushing yourself out of your comfort zone, but hopefully there's so much learning that happens about anxiety, about people's ability to cope with anxiety and distress, and about those beliefs as well. Different things did different things happen to what you was expecting would happen when you put yourself in that scary situation.
Random arrow in the middle. Yeah. No, sorry about that. I think I've been doing too much chatting today. My usual problem. So this is just some kind of key things, and I'd really be keen to hear if other people have got things they'd add to this. Is there another start? No, there's not. So these are the things that we think really make the difference, and I've kind of tried to put them in a bit of a logical order. So the first thing, and this is another classic thing that I think can sometimes not happen, is it's live practice with the therapist every session. And I think quite often, perhaps in other forms of CBT or in CBT for other difficulties, it's kind of okay that you can talk in the session and you can say how your week's gone and you can then go away with some homework to practice. We know that actually the exposure tasks that we're asking people to do with BDD are just too hard. There's going to be too many layers of avoidance and distress and lots of reasons why people just aren't going to do that unless they actually have quite a lot of hand-holding. So I think one of the young people in the videos at the beginning talked about how Benny went to their school and was kind of sitting outside, so she knew if it kind of went pear-shaped, she had Benny outside and she was going to safely be taken home. And actually, I think she described, I wouldn't have done that if I hadn't had someone there with me. Like actually, that live coaching, that opportunity to really spot if there are any subtle behaviours that maybe the person's not even aware that they're doing, but generally just to provide that support and to say, we're going to do this with you. I always say to people as well, I'm never going to ask you to do something I wouldn't do myself. So we're often taking all our makeup off and messing up our hair and walking down Camberwell High Street, which is where we're based. And it's difficult. I'd never expect someone to do an exposure task that I wouldn't do myself, and we always say that to people. So that is a really key thing, and I think if you're thinking about accessing treatment for yourself and you're looking for how you kind of work out if this is helpful or not, I'd say that's a really important thing to be looking for. And that every session thing is important as well. And that's really hard. I mean, sometimes I think we feel, someone comes in and they've had a really bad week and they want to talk about that, and we're there, these real sticklers with the manual saying, yeah, we need to still do an exposure task. And that can feel quite, I think it can feel quite strict, but it's because we know the exposure is the bit that makes people better. And actually, there are lots of other types of therapy and lots of other settings where other kinds of support are available, but if you're coming for BDD treatment and you want to get better from BDD, that's the thing that needs to happen every session. I mean, obviously there's flex in that. I'm not saying we're completely immune to any necessary kind of adaptations and things to look at, but generally speaking, we know that's what we're looking for. Like collaborative planning is really important, and Katie's talked a bit about planning, but that collaborative bit's really important, right? We're not going to tell people what they need to do. Equally, we're not going to expect people to plan tasks on their own. We're going to do it together with them, and we're going to agree things that really are things they want to achieve. They're things that are meaningful in their life, not things that we think they need to be doing. So 9 times out of 10, we're not saying, how do you get back to school, unless that's what they want. It's how do you get to the Taylor Swift concert. These are the things that matter in people's lives. These are the things that give them purpose and joy. And so we want to be working on goals that matter to them. Because I wouldn't do something that was really hard if I didn't care about the outcome. So I wouldn't expect, the person I'm working with to do that either. Starting small, really important. It doesn't have to be a big kind of grandstand task, certainly not in the beginning especially. It can be something really tiny. It could be, taking off a tiny bit of eyeliner, or it could be just looking up, getting eye contact with someone for a split second, or often it can feel, I think, as though it's really small steps, but it's so important, because if you can do that, especially if you can do it without any safety behaviours, you've had a massive win against BDD, and it gives you that foundation to then gradually build up. And sometimes we'll start a task and it is too hard, and we need to then say, right, okay, that's fine, let's break it down, how do we make it easier, let's try again. Sorry, my voice is going to go. So it's never, let's give up completely, it's how do we break it down, how do we, we move on, what's the next thing we do? I've said about resisting or safety behaviours, so We've talked a bit about that already. We talked about how self-focused attention is really problematic. So obviously when we're doing the tasks, we want to make sure people are focusing externally. This is another thing that having the therapist live with you can be help. Another reason it's helpful, because as we're walking around, we can be saying, where's your attention? What are you looking at? Are you noticing, the birds flying, or are you just really, really thinking about how your nose looks? So we're wanting people to open up and to focus their attention externally, because we know that's what the skill that people need to learn to do. Regular practice, so it's not just that weekly session with us, it's something that people are hopefully practicing every day. It's what we always aim for. Sometimes it might be a bit less, but the practice is what's going to count. Doing a one-off task in the session isn't the thing that's going to make you better, it's doing it again and again and again. So it's another thing we're quite bossy about, stuck records about. Reviewing the learning, so not just have you done the task or not, but what did you learn from that? And sometimes the learning could be, something we've not thought of, but actually each individual is having these new experiences, they're doing things differently, what have they taken away from that, and constantly checking in and really consolidating what that learning is. And the final one is rewards. As I said, everyone needs to have a reason to do things. This is, I think, where parents can be really helpful, not necessarily just with bribery, although I think sometimes a little bit of bribery goes a long way, but it can, it can be any kinds of experiences that actually celebrate achievements and offer people kind of a reason to keep going and keep that momentum going. This back to you, wasn't it?
So another kind of element of treatment, which is very similar to an exposure task but slightly different, is something called behavioural experiments, which some people may have some experience of in the room. So I guess what in exposure there is a chance for kind of learning about those beliefs and testing those out. But I guess the main element is kind of putting yourself in that scary situation, not doing those safety behaviours and getting used to that anxiety over time. So in behavioural experiments, what we're looking to do is kind of test out some of those beliefs. So people might have really strong predictions about what they think is going to happen in a certain belief that kind of the BDD is driving for them. So a behavioural experiment gives us the opportunity to kind of name those and test them out in a kind of experimental way. So these sorts of things might be about making predictions about how people are going to respond to them when they walk out and about and not doing those BDD safety behaviours. It says making predictions about what will happen if you don't use the safety-seeking strategy, so if you're not asking for reassurance. And I've mentioned before, but I think a really important one is thinking about how people's beliefs about how they're going to cope with things. So I guess when setting up a behavioural experiment, we will be picking very similarly to an exposure task and thinking about the BDD behaviour that you want to be resisting, but it's sort of designing it in a more of an experimental way. So you really sort of operationalise that and you're saying, okay, how are we going to test that out? How would we know in real objective terms if someone was responding to you negatively because you didn't wear your hat? And I think that objectivity is the real key bit. So we want to really pin down with that person before we do it. How would we test that out in a kind of factual, objective way? And you might want to start thinking about other things as well that might be happening in those experiments. So thinking about sort of different thinking styles that might be coming into play. So for example, misinterpreting people's facial expressions is something that's really common in quite a few people that I've worked with. So we really want to kind of name that and think about, okay, we're not going to use that as a kind of reliable piece of evidence in this task. So really sort of laying all that out and operationalising all of that. Towards the end of treatment, so the last couple of sessions we spend doing this, we do something called relapse prevention. Sometimes it's called a therapy blueprint. And it's really, really important part of the work. So I guess what it's doing, it's giving us an opportunity to kind of reflect back about everything that we've done over the treatment sessions, really think about what you've learnt in those sessions, what's been important. And the next part of that is also thinking about if there's work left to do. So quite often at the end of the treatment sessions, there might be a bit of BDD still around. And it's kind of naming that and labelling that and putting down, okay, what are the things that I need to kind of continue working on even though the weekly treatment sessions are finished. I guess a big aim of CBT is to kind of hand over those skills to kind of train someone up as their own therapist so that they can kind of continue that work. And that's all built into the relapse prevention plan, so kind of thinking about the things that might still be left to work on and making a bit of a plan on how that's going to happen. Another important part is thinking about vulnerability for times when BDD might try and push back. So we know that kind of around times of stressful events happening, when you're ill, when you're tired, you become more vulnerable to kind of BDD related thoughts. So putting all of that into the plan and making a really detailed plan about, for example, do you have exams coming up soon, and then making it really predictable that that could be a time when BDD pushes back. And keeping well, and then what to do if you do relapse from BDD. I guess relapse for BDD does happen, but it's kind of making a good solid plan. And I guess even kind of reframing that and thinking about it in a positive way, that if a relapse does happen, it gives you a chance to kind of put these skills into action. You have these skills now, and it's about kind of using those and when to do that. But I guess sort of pointing out the times and making it a bit more predictable about when that might happen. I think the last thing that we were going to think about was, we've talked about the real key components of CBT for BDD. There are some other things that we do use in our treatment manual, but we don't use with everyone. So these are our additional treatment components. And some people in the room may have had some experience with some of these things. So, for example, we do something called mirror retraining, which is learning about giving opportunity to think about dealing with mirrors and photographs, so thinking about the way in which someone might use a mirror and how that might be really unhelpful and kind of keeping BDD going. Challenging negative thoughts, so I guess you get an opportunity to do that in some behavioural experiments, but really sort of picking that apart and thinking about maybe different styles of thinking that might be contributing to that, and thinking about alternatives. Attention training, so we've spoken about sort of that self-focused attention and how that's something that's really important in keeping BDD alive. So helping people sometimes to start to retrain their attention. We start to think about attention as a muscle that you kind of want to build up. So we have some sessions there where we can practice, sort of starting to practice getting that attentional control and focusing more externally when you're not feeling anxious. So when you are feeling anxious, it's kind of easier to kind of put that into play. Building self-compassion, so starting to recognise that kind of inner critic, that inner bully, building insight around that and thinking about ways that you might start to challenge that and take a bit more of a compassionate stance towards yourself. And then the last part is reclaiming life from BDD, which I guess we're doing all the way through treatment, where we're sort of, where that person's kind of putting themselves in that scary situation. It's usually something that BDD has kind of shut down for that person in life. So thinking about things that that person used to enjoy and kind of building that back in, especially where hopefully BDD started to decrease, filling that time that BDD used to with all the things that sort of bring that person pleasure and joy and enjoyment and make them feel good about themselves.
All right, so we just thought we'd run through the care pathway. This is probably a bit dry, but I think from speaking to people today, we're just acutely aware that actually accessing these kind of treatments is often the biggest challenge that people are facing, and so we thought we'd just run through. This is our understanding of how the pathway should work, but also acknowledging that there can be some big obstacles in the way in terms of waiting lists and accessing that kind of care. So the pathway is designed to kind of ultimately start off with the GP. So the majority of mental health services, certainly within the NHS, all require that initial contact with the GP. Now, there's actually some mental health services where you can go straight from your GP to the specialist service. So, for example, CADAT, which is the adult mental health service at the Maudsley, so kind of our sibling service, I get our older sibling service. They actually have something called GP Choice, which people might be aware of. It kind of applies to various conditions, and that actually means that in theory you can go to a GP and say to them, actually, I don't want to go to my local service, I want to be referred direct to a specialist BDD service, and you have a right to do that within the system. It relies on the service saying that they accept GP referrals, and so the reason we've mentioned CADAT is because we know that they do. That isn't because they're the only service that do. We don't actually. So working with children and young people, we require people to come through their local CAMHS team, and that's primarily because we don't provide care coordination. We can't provide kind of locally based risk assessment and risk management. It would, we're working with people all over the country, and we wouldn't be able to provide that level of wraparound care. So we actually work collaboratively with the local CAMHS team, with us providing the specialist BDD input. But certainly there are some services for adults where perhaps people don't need that level of wraparound care, and they can just have a relationship with the GP and the specialist BDD team. So your GP is still your first port of call, but whether or not you are being referred through to a local mental health service or directly via patient choice is something to discuss with your GP and to kind of find out what's available for you. Then obviously you need a good assessment. So that would, as I say, for young people, that would be with your local CAMHS team. For adults, it may be your local CMHT, or it might be through IAPT. If people are familiar with IAPT, that in some local areas, it's the IAPT services that provide that kind of initial screening and assessment. And that's important because actually it's important to know if there are other difficulties that are going on. You know, it might not just be BDD in isolation, or it could be conditions like social anxiety or eating difficulties that look very much like BDD, perhaps to carers, but actually there are other things, and it's important to know that because the treatments would be different and what's required for recovery would be different. So that assessment is very, very important. Obviously, at that point, you're looking at whether or not BDD is being seen as the kind of primary priority in terms of treatment, or if there's another condition. So that takes us to our points 3A and B. And then it's who is the best person, you know, who is the best service to be providing this. Now, there are some areas where BDD treatment is being offered by local teams. We are frequently providing training to local CAMHS teams for sure who are able to provide CBT for BDD and have the expertise within the local teams to do that. And obviously, there are lots of advantages to only needing to go to a local CAMHS team as opposed to travelling to see us in South London, particularly if you're living much further away. We're also aware that in some areas the CBT provision is minimal. Again, we particularly have experience of children and young people, but I'm sure that's the case for adults as well. And so even finding a CBT therapist, let alone somebody who feels kind of equipped to support someone with BDD, might be a challenge. So if that's the case and you really, you know, you're not able to access that treatment locally, that's where the specialist services come in. So that's services like the one that we work at, but there are also, I think, 4 or 5 adult services. I've got another slide in a minute to tell you where those are, who provide this national specialist, and they're all OCD BDD teams. So all of the services work with both conditions and other related disorders. There's a few other related disorders that kind of where the same kind of treatments are helpful. If you do make it to us, obviously we're looking at assessment, thinking about what intervention is useful, and then we have a process where we follow people up for a year after we've done the active stage of treatment, which is really important because that's, I think, when people are trying out skills but for themselves, that's where actually having an opportunity to check in. We only check in 4 times in that year, but they're really key kind of parts of the intervention because I think that's where you really start to put into practice the skills that you've learned. And I think having somewhere to bring that back to and reflect on that can be really helpful. And then at the point that you get discharged from your national service, you may go back to your local service if you still need support, or it may be that you're discharged. We talk about discharging you back to your GP, so i.e. not needing any more mental health services. So that's the care pathway. We just thought we'd include it because I think often people aren't clear about what the landscape is and what the different levels of care are, but hopefully that makes a bit of sense. And then these are the services that are currently providing specialist BDD support. So us at the top, we took the top spot, not for any particular reason, we took that spot. So we provide outpatient care for young people. We do have access to a bed on our local adolescent ward, but that's for people who are already in treatment with us and where we want to kind of do perhaps a slightly more intensive or a part of their treatment that would work better in hospital, but we don't have access to beds where we can admit people in straight from the community. If that is needed, the Priory Hospital, so the 4th one down, the Priory in North London have access to beds for adolescents and for adults. So but we gatekeep the adolescent beds. So we would do the assessment and then we would kind of make the recommendation that somebody makes use of the North London Priory beds. Those beds can also be accessed through separate funding by your local areas. So if somebody, I think there were questions earlier about beds for young people, there are these beds, but they're in very, very short supply. And actually, I think there's a very strong argument that, particularly for young people, keeping them in their family environments really is better for them. So we would only want to make use of inpatient care if we really have to. I think for adults, there's probably different factors at play. Hiya.
Thanks for taking the question. Not Priory Hospital, is there no
I wouldn't want to say 100%. We're part of a network of highly specialist services, so most of my information comes from that. My understanding, in terms of the NHS England funded work, the outpatient care comes from CADAT, who you can see at second on the list, and also Springfield in southwest London and Hertfordshire. I don't think they do, but if Himanshu was here, he might say otherwise. It's certainly not the NHS contract, but I think if you were accessing that privately or possibly through a different funding, it might be that they can have. Did you think that they did?
No, it's just that that's the most local to where we live.
Yeah, they've got, their contract is slightly different because obviously they're a private hospital, so I've got a feeling that their contract is quite specific. But all of these services, these are all national services, so where you live doesn't limit your access. Obviously, the practicalities of getting across London or wherever it might be is different. So the other thing to point, in southwest London there's a ward, CCOL ward, where they offer an inpatient care for people with OCD and BDD. So that is the only entirely specialist ward, and that's for adults. But then there's also the residential unit. I'm all right. No, don't worry, I'm fine. I'll battle through. There's the residential unit at the Bethlem Hospital. So this is the third one down. I don't know if people are familiar with ADRU, if anyone heard of that. It's a service I've got a real soft spot for because I think it's actually really powerful and can be really important for people at the right time in their life because it's residential rather than inpatient. So the staff will go home at 5 and it kind of relies much more on the power of the community in terms of the recovery, and they do lots of groups and lots of... I think it's really helpful for people who really wanted to rebuild and to look at perhaps broader aspects of their recovery, but who don't necessarily need 24-hour nursing care. So yeah, that's another service that is available for people with BDD, and I think, as I say, at the right time in people's life can be really kind of transformative. So yeah, that's just an idea of the different specialist services, but we're pretty much on our own when it comes to young people. But we do provide a national service. I think that was it. So we've left about